You've probably heard of the term diabetes before, but do you know exactly what diabetes means? If not, stay tuned, because by the end of this video, you're going to understand the concept of diabetes. You're going to know how to interpret diabetes results. You're going to know how to prepare yourself as a patient from the house before even visiting the hospital to undergo a diabetes test. And if there is more time, I'm going to show you how to manage a diabetic patient and some of the drugs to give to the diabetic patient in order to help curb down his or her situation. All right. Now, just a disclaimer before we start this video. I want to make this video very simple in that anybody at all can consume it. In other words, you don't need any prior medical knowledge to understand it. I'm going to try my possible best to digest each and every medical term I use here. So don't worry about whatever thing you are seeing from behind me. By the end of this video, you're going to understand it and you're going to feel like a genius, bro. So stay tuned, okay? Now, we've all heard of the term carbohydrate before. Now, what are some of the food sources we can get carbohydrate from? Of course, I don't need to make mention of this, you know it. But what I want you to know here is that the main chief sources of carbohydrates include starch, lactose, sucrose, and what? And cellulose. But what is starch exactly? Now, let's take a look at starch on a molecular level. I want you to see how it looks like on a molecular level because it's very, very necessary to the understanding of certain concepts, okay? So this is how starch actually looks like on a molecular level. And you can see that it is made up of certain substances from within it. These substances are referred to as glucose units. So this is a glucose in that order, okay? And if you take a closer look at it, they are being held together by two strings, okay? We refer to those strings as glycosidic bond, okay? The linkage here is called a glycosidic bond, but more specifically, it is alpha-1,4 glycosidic bond. Forget about the name, it is just a fancy name we are giving to it, okay? So alpha-1,4 glycosidic bond. And this alpha-1,4 bond can be found throughout this particular starch molecule. So this is 1,4, this is also 1,4 in that order. However, there is a little twist in here. You can see this is in a linear form. However, there's a part of the starch that is branched, okay? Now, this particular part of the starch, it is not alpha-1,4, it's alpha-1,6 glycosidic bond, and this is very necessary. So as I begin explaining, you get to understand why. So yeah, let's take it as we've taken a source of carbohydrate, okay? We've taken a carbohydrate which contains starch, okay? So when we take the carbohydrate in, there's a gland in our mouth referred to as the salivary gland, and this particular gland produces an enzyme called the alpha amylase enzyme. Now, the alpha amylase enzyme is actually inactive. It doesn't work unless it comes into contact with what we refer to as the chloride ions before it becomes active. If you are thinking of what chloride ions mean, just think of salt. You know, usually we say sodium chloride, sodium chloride. That particular chloride is what I'm talking about in here. And it can come into contact with alpha amylase in order to activate the enzyme. When this enzyme is being activated, it is going to break down the starch that is inside your mouth. It is going to start to break it down. How does it break it down? The enzyme here is going to act like a scissors. Take a look at this. It is going to act like a scissors. So when it comes in here, look at something. It is going to cut this thing into two. It is going to cut this thing into two. It is going to cut this thing into two. And it's going to cut this thing into two. So you can see this particular enzyme is attacking a specific type of bond, which is the alpha-1,4 bond within the starch and not the alpha-1,6 bond. I hope this concept is quite clear. Now, why am I saying this? This is because anytime starch is being digested in your mouth, this is what you get. You see, we break it down, alpha-1,4 bond, we have two sugar molecules here. We have two glucose units, we have two glucose units, we have two. Now, these two glucose units here are collectively referred to as a maltose, okay? So you can see in here, let me use a different color to make it more clear. Oh. So here we have maltose. Now, this particular remaining sugar here, which is the glucose, at the branching point of the starch, this thing is referred to as what? An isomaltose. So this is an isomaltose. So you can see Although it is glucose, 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 the differences lie in the type of bonds that is found in them. So here, glucose, glucose, the bond here is alpha 1 for bond together. So this is maltose. And this thing here is what? Is isomaltose. I hope this concept is very, very clear. Very good. Now let's move into it. So you see, this is the starch. The amylase, which is the enzyme, is acting like a scissors and cutting all these things up. And this is the result we get from that. We get what? We get isomaltose and we have maltose. Just as I said here, we have maltose and then we have isomaltose. This is the product you get inside your mouth upon digesting what? Starch. You might be asking yourself, then where is this starch dextrins coming from? The thing here is that when you put food inside your mouth, the food remains temporarily in your mouth. In other words, we only partially digest starch inside our mouth. We don't completely digest it, we partially digest it. And as a result of that, other different products might be formed. Okay, those products that are formed are referred to as starch dextrins. So you see dextrins like acrodextrin, erythrodextrin, and then what is the name? Yes, these are just different. You don't really need to know the names of it, but I'm just making mention of it. So this is where the dextrins are actually coming from. That is where the dextrins are actually coming from. Now, you can see we also have lactose, we have sucrose, and we have cellulose. After it went into our mouth, we still have lactose, we still have sucrose, we still have cellulose. Why is that so? Why is it not changing inside our mouth? The reason being that the enzymes that are required to digest the lactose, sucrose, and cellulose are not found in our mouth. We would have to move the food down before we meet those enzymes. So yes, inside the mouth, these are the things you have inside your mouth after you take in a source of carbohydrate. Okay? Now the source of carbohydrate can either be starch, it can be lactose, it can be sucrose, it can be any of this. I hope this concept is very clear. Very good. Now, as the food moves down the esophagus, it will get into the stomach. When it gets into the stomach is usually acidic in nature. When we say something is acidic, in other words, the pH of it is very low. Low pH means it is acidic. High concentration of hydrogen ions also means something is acidic. So you can see here I've written low pH stops the action of salivary amylase, which means when all these things get into the stomach, no enzyme can act on it. Alright? Because the action of this enzyme is being stopped. So they will pass through the stomach safely till they get into the small intestines. Now what happens in the small intestines? Now inside the small intestines, there is an accessory organ we refer to as the pancreas, and that is what I've drawn in here. Now the pancreas releases an enzyme we refer to as the pancreatic alpha amylase. Don't forget, we have amylase here and then we also have amylase here. But this is exactly coming from the pancreas and not the salivary gland. And it acts differently. How? Let's take a closer look at this. Now I told you the starch here actually is going to be digested by the alpha amylase acting on it. Now don't forget, usually when we cook food, some part of the food might be well cooked and some part might also not be well cooked. Okay, so in case, okay, this is just a hypothetical statement I'm making. In case the food is well cooked, it means most of the starch in that well cooked food will be acted upon by the salivary alpha amylase, the amylase inside the mouth. However, when some part of the food is uncooked, the uncooked part cannot be digested by this particular amylase inside the mouth. But when it gets down into the small intestines, the uncooked part of the food can be digested by the pancreatic alpha amylase. I hope you note the difference. So here is a cooked starch and here is an uncooked starch. So let's look at the things we can get out of that. So let's say the starch is uncooked. So when the starch is uncooked and it comes here, the same thing, the same process is going to happen. You are going to get isomaltose, as you can see in here. You are also going to get maltose as a result of that. I hope that is clear. But don't forget, the lactose and sucrose and cellulose are still going to be the same because they've not gotten to a place where their enzymes will start acting on. Okay? So as you move along the intestines, it will get to a part of the intestines referred to as the 𝐤𝐴𝐺. Now, don't mind the name. The intestines, which is the small intestines, is divided into 3 different parts. The first part of it is called duodenum. The second part of it, which is the middle part of it, is called the jejunum, and then the end part of it, the tail end of it, is referred to as the ileum. All right, let me draw it here to make it try to make more sense to you. Okay, so let's say this is the intestines. Okay, all right. So the beginning part of the intestines is called the duodenum. All right, the middle part of it, okay, let's say this is the middle part, is called the jejunum. And then the end part of it is called the ileum. All right. So all these food substances you are seeing in here are going to be inside the what? The intestines. Specifically, the jejunum part of the intestine, the middle part of the intestines. And what is going to happen here? Inside the intestines, you know, there are these finger-like projections. There are these things within your intestines like fingers. And in these particular things, there are enzymes that are being stored there. We call those enzymes disaccharidases. Don't mind the name. Just note that there are enzymes inside your small intestines, and we need those enzymes in order to help us digest all these food substances, because we cannot absorb them just as they are. We have to convert it into something before we can make good use of it. And how do we do that? So look at what is going to happen in here. This is lactose, we have lactose here. This is maltose, we have maltose here. This is sucrose, we have what? We have sucrose here. This is isomaltose, we have isomaltose here. So all the food substances are here. And I'm telling you that in the intestines, we have something referred to as disaccharidases that are going to help us in the digestion of all these particular carbohydrate sources, right? So look at something. Disaccharidases. This is the name of the enzyme. Collectively, but specifically, they have their own names. So look on the board. For lactose, we have an enzyme called lactase. For maltose, we have an enzyme called maltase. And then for sucrose, we have an enzyme called sucrase. And then for isomaltose, I know what they are thinking. That is not it. But we have an enzyme called dextrinase. So all these enzymes are collectively referred to as disaccharidases. What are they going to do? They are going to act on each and every one of these substances to break them down into 2. So you can see we have glucose galactose, we have glucose fructose, we have glucose, and then we have another glucose in here. So that is why we refer to it as di. You can see they are divided to give us some, 2 different substances that are in the form of sugars. Okay, so yes, that's what you get. So coming back here, we know we have glucose, which is glucose. We have glucose here, we have glucose here, we have glucose here. Why this number of glucose? There are lots of glucose. Now this should be telling us something. But before I come back to that, let's take a little bit of something. So this glucose that has been gotten, all this glucose, I've written it as 1, that has been gotten from the digestion of all these things, is going to enter, it's still inside the small intestines. Okay, now the intestines is actually connected to your liver by a certain type of vein. We refer to it as the portal vein. Okay, so the glucose that is inside the intestines is now going to move through the portal vein, okay, and get deposited inside the what? The liver. This is your liver. I repeat again, the glucose is going to move from your intestines. It will move through the portal vein, which is a vein that connects your intestines to your liver, so that the glucose can be deposited inside the liver. Now we are not done. You might be asking, if that is happening, then what is the fructose, or where is the fructose and then the galactose going to go? It is the same thing. They are also going to be absorbed from the intestines. They'll pass through the portal vein, then they'll get deposited in the liver. But this is the twist. The galactose and then the fructose will also get converted back into glucose inside the liver through a series of pathways, which I don't want to discuss because it's going to be very long. So we are not discussing that. But just know that the galactose and the fructose is also going to get converted into what? Into glucose inside the liver. So the whole idea here is that when you take in carbohydrate, whatever source it might be, whatever source the carbohydrate might be, you can't absorb it just as it is. It has to undergo a series of processes, and the end product of all these processes is that you are going to be getting a substance we refer to as glucose. I'm explaining this because this is very necessary to understanding the concept of diabetes. Okay, so we are going to get what? Glucose. Very good. Now we are done with the glucose, and the glucose is now inside the what? The blood. This is the glucose. It is inside the what? The blood. But just a second, before I come back to this, I know you are still thinking of the cellulose, right? We added cellulose here, but all of a sudden it disappeared. We didn't talk much about it. The reason being that cellulose usually cannot get digested in our system. Okay, we have substances, we have food substances that contain cellulose, but when we take it in, we do not have enzymes to help us digest the cellulose. So the cellulose we take in comes out just as it is. But what is the advantage of it if you can't digest it? The advantage is that inside your small intestines, it helps with water retention. And helping with water retention simply means that it helps you to produce very softer and larger feces. In other words, it will help prevent you from constipation. So just a rule of thumb, if you are somebody that is suffering from constipation, our advice is that you should take a lot of orange, you should take a lot of watermelon, a lot of berries, a lot of pears. I don't know how you call it in your home country, but it is spelled as P-E-A-R, a pear. I mean, this sort of fruit and even apples are very rich in cellulose, and they can help with what? With constipation. So that is the little thing I'd like you to know about cellulose. Now let's come back to what? To glucose again. So these are the glucose units that are found inside your blood now. Now we know where the glucose is coming from, isn't it? Very good. Now, this pancreas you are seeing in here, it doesn't only produce pancreatic alpha amylase as an enzyme, but it produces a type of hormone referred to as insulin. Okay, so there's another substance that this thing can produce, and that thing is referred to as what? Insulin. This is what? A hormone. A hormone. Please take note. So I'm bringing the hormone here for you to see. So this is insulin. What is the insulin going to do? What is the insulin going to do? What the insulin is going to do is that it is going to help us bring in some of these sugars into our cells. Now let me brief you on something. This particular glucose unit that is found inside our blood, we don't want it to stay inside the blood. We want our body to make use of that particular glucose, because that is the, what is the goal of eating? We are eating because you want to get energy. How do you get energy? We get energy by moving the sugar that is inside the blood into our cells in order to generate that particular energy. So this is a very key example. This is a kidney. Okay? Now a kidney is an organ. It can be any organ at all in the body, but I'm just using the kidney as a principal example to explain the concept. Okay? So if you're taking the kidneys here, now the kidney is made up of thousands, if not millions of nephrons. And when I say nephrons, I mean the substances, the cells that are coming together to form the whole kidney. For example, if you have a building, the building didn't just come from a place and yes, it started or it appeared from the blue. No, you started by putting one brick on top of the other. In this particular place, in this particular case, our brick here is a nephron. So a nephron, a lot of these things are coming together collectively in order to form what you refer to as the kidney. I hope I'm making sense in here. So this is the whole kidney, but I'm trying to zoom in on one of those particular cells, which is the nephrons. So that is why I drew this thing. So this is what? A more zoom picture of one nephron, just a single part of that particular nephron is what I've zoomed in order to explain the concept of diabetes to you. If you've been able to make it through this video so far, don't forget to give me a thumbs up and leave a comment in the comment section below. Let's continue. Now, I made mention of insulin and said the insulin is coming from the what? From the pancreas. Now, these things you are seeing hanging out of the nephron, now we know what a nephron is, the basic unit of the kidney. Now, these things that are hanging out are referred to as receptors. Okay? They are called receptors, and these receptors are found on the surfaces of almost all cells in our body. It is just that I'm zooming in on the kidney. So what the insulin does, let's say this is an insulin molecule, okay? This whole insulin, I'm drawing it as a circle. What the insulin does here is that the insulin usually comes like this, then it will come and bind to one of the receptors. So let me draw it this way. The insulin is going to come this way and come and bind to one of these receptors, or it can also bind here. Whatever place it might be, is going to bind to these receptors. Now, when it binds to these receptors, it is going to open up certain channels, because initially these things are closed within the nephron. But when the insulin binds to this particular receptors, it sends information to the cell that something has been attached to me, and this is exactly what I want you to do now. So this particular thing is going to send an intracellular information. There's a cascade of events that is going to happen. And what is the response to that? The response to that is that the cell is now going to open up. The cell is now going to open up within the kidneys. And what is going to happen? The glucose, the sugar that is inside your blood. When we say sugar, sugar is just a fancy name for glucose. Okay, so when I'm saying sugar and I'm saying glucose, I'm referring to the same thing. Okay, so when these channels are open, this particular sugar is now going to rush into the cell. So these are the glucose units. Let me write the name here. Glucose is now going to rush into this particular cell. Now, logically, if I'm taking glucose and moving it into the cell, it means the amount of glucose in the blood is now going to begin to decrease. It's now going to begin to do what? To decrease. And then the glucose inside the cell cannot be utilized by the cells. In other words, it can be utilized by the kidneys in order to generate energy for it to perform its functions. I hope I'm making sense here. But this now brings us to the definition of diabetes. What is diabetes? Now, diabetes is when you have a trouble with your insulin production. Probably your insulin is not working, or the receptors that are supposed to respond to the insulin is not working. So logically, what is going to happen in here? We cannot bring the sugar from the blood and send it into the cells. In other words, there will be accumulation of glucose unit or sugar inside our blood, which we refer to as hyperglycemia. Hyper means high, and glycemia has to do with the sugar concentration inside our blood. So we are going to have high concentration of sugar inside your blood. Why? Because you cannot actually put the sugar into the cells. And what is the reason for that? It might be because you have a problem with this particular insulin. Your pancreas cannot secrete insulin, or your pancreas might be secreting the insulin, but the receptors are not responding to the insulin. You see that? So that is what you refer to as diabetes. Diabetes is a condition whereby you have a problem with your insulin, or you have a problem with the receptors that are actually responsible for responding to this insulin, and thereby, as a result of that, you'll be having high levels of sugar inside your blood. Now, there are different types of diabetes. We have type 1, we have type 2, we have gestational, which affect pregnant women. We have other different specific types, but I don't want to explain all. I don't want this video to be long. The most important thing is that you understand the basic concept. When we say diabetes, it means your blood sugar is very, very high. Technically, we refer to it as diabetes mellitus. Diabetes mellitus. What do you mean by diabetes? This diabetes is actually coming from the Greek word. Okay, it's a Greek word, and then mellitus is a Latin word. When we say diabetes, it simply means to siphon something. To filter something, to siphon it. Okay, and when we say mellitus in the Latin language, it simply means something that is sweet. Something that is sweet. So here they are referring to the glucose unit that can be found in the urine. Because one of the symptoms, okay, I'm not going detail, but I'm giving you something to just understand. One of the symptoms of diabetes is that you urinate a lot. Okay, not only do you urinate a lot, but you can find glucose, which is sugar, inside your urine. In other words, it's being siphoned through your kidneys. So that is where the name diabetes mellitus is coming. Now, sometimes you might also see the term diabetes insipidus. It all has diabetes in it. The reason being that their clinical symptoms tend to be the same, in that those type of people tend to urinate a lot. Now, in science, when somebody is urinating a lot, we refer to that as polyuria. And if you are urinating a lot, in turn, you find out that you are losing a lot of water. So you want to drink more water, right? So it means you'll be thirsty also. Now, the scientific name for thirst is referred to as polydipsia. Okay, so we have polyuria, which is urinating a lot, and then polydipsia, which means thirst. These two symptoms are being shared between diabetes insipidus and diabetes mellitus. That is why you see diabetes in it. But what do we mean exactly by diabetes insipidus? Now, in the case of diabetes insipidus, the problem is with an hormone called the antidiuretic hormone. But in the case of diabetes mellitus, our problem has to do with insulin. I hope it's making sense now. In the case of this diabetes mellitus, which is actually one of the common cases, this one is actually rare. This is very, very common. That is what we usually see in the hospitals. You have a problem with insulin. But in the case of diabetes insipidus, you have a problem with your antidiuretic hormone. Let me explain further so that you understand diabetes insipidus. Maybe during, if I'm arranging this video, I might put a small diagram on the screen for you to see the explanation. But let me just give you a very simple discussion here. For diabetes insipidus, it's simply when you have a low blood pressure, okay? So people with hypertension, when you have a low blood pressure, there's a certain part of the kidney we refer to as the juxta glomerular. Now, the low blood pressure is a stimulus which will stimulate your juxta glomerular apparatus in the kidneys to produce a substance called renin. So let's take renin and put renin down. Your liver produces a substance, a protein called angiotensinogen, okay? So what the renin from the kidney is going to do is that it's going to convert the angiotensinogen into a molecule called angiotensin 1, okay? Now, we have angiotensin 1. Your lungs, the pulmonary surface of the lungs produces an enzyme called the angiotensin converting enzyme, and also the kidneys can also produce this enzyme, angiotensin converting enzyme. So it's going to help to catalyze the conversion of angiotensin 1 into angiotensin 2. So when we get the angiotensin 2, it can do a couple of things, a lot of things. But I'm not interested in all those things. I'm interested in only one thing, which is what? The ADH. Now this angiotensin 2 can act on a certain part of our brain. We refer to it as the what? As the hypothalamus of our brain. Like I told you, in every part of our body, there are these finger-like projections coming out. We refer to them as receptors. So this angiotensin 2 is going to be what? Attached to certain receptors in our hypothalamus. The hypothalamus is a structure which is part of a brain. It is located in one part of our brain called the diencephalon. You don't need to know that. Just know it is found inside your brain, okay? So when it attaches itself to the hypothalamus, it is going to stimulate certain cells within your hypothalamus, referred to as the supraoptic nucleus, to produce a substance called ADH, which is the antidiuretic hormone. When this substance is produced, it is going to move down those particular supraoptic nerves and get stored inside your posterior pituitary gland. So when it gets stored inside, anytime the body is in need of it, that is when you have a low blood pressure, you see that the ADH will be released. This thing is too much. Let me draw this thing here for you. So in the brain, you have something like this. Okay, we have something like this. This place is called the what? The thalamus. Okay, thalamus. This is the what? The anterior pituitary gland, and this is the what? The posterior pituitary what? Gland. Okay, so what the angiotensin 2 does is that it is going to bind itself to certain receptors. Okay, they are called osmoreceptors. So they are going to bind to these receptors, and these receptors are also going to what? Help certain nerve tissues which are found inside the hypothalamus. They spread, they are axons. They spread like this through into the what? The posterior pituitary gland. Sorry, they spread like this into the what? The posterior pituitary gland. So they are going to stimulate these cells to produce a molecule called ADH, antidiuretic hormone, which will get stored inside this part of the what? Of the brain. So anytime you have a low blood pressure, the ADH is going to be released. The antidiuretic hormone is going to be released. And when it's being released, you know what is going to happen? It's going to get inside the kidney tubules, a part of the kidney called kidney tubules, specifically the collecting duct of the kidney. When it gets into that place, it is going to absorb some water from your urine and bring it back into your blood. So, initially you had a low blood pressure. So what we just did is that we've now increased your blood pressure back to normal again because of the ADH, the antidiuretic hormone. Now, in the case of people that have a low amount of ADH hormone, we refer to those patients as having diabetes insipidus. Why? Because when you have a low ADH, you cannot absorb water. If you cannot absorb water from your urine, meaning you'll be urinating more than usual, you urinate like you are crazy, we refer to that as polyuria. And if you are urinating more, you are going to become thirsty, so it will lead to what? Polydipsia. So you can see there is polydipsia and polyuria in both diabetes mellitus and both diabetes insipidus. The difference lies in the type of hormone that is being affected. I hope I'm making sense. I'm speaking slowly and prolonging things just to make sure you are getting what we are talking about. All right? I think yes. So that is it for the explanation of diabetes. Diabetes simply means that you have high levels of sugar inside your blood because you have a problem with your insulin, or you have a problem with the receptors that are supposed to respond to this particular insulin. Now you might be asking, of course, if your glucose is not high, it might be low. So in a situation where you have low sugar level, we refer to that as hypoglycemia, meaning you have low amount of sugar inside your blood. Hypoglycemia. And how do we measure that? And usually when you have sugar levels somewhere below 45 milligram per deciliter, then we say you are suffering from hypoglycemia, which is a very, very dangerous type of condition. All right, so we have hyperglycemia and then we have hypoglycemia. Now, here comes the most important part. When you are going to the hospital, or when you get to the hospital and then we take your blood sample, your urine sample, or whatever, then how exactly do we investigate you for diabetes? How do we know that this patient is suffering from diabetes? Because now we know diabetes means you have high blood sugar. Now, how do we do that inside the lab? Now, this brings us to the investigation of diabetes. Now, there are two different things we do when it comes to the investigation of diabetes. First and foremost, we have estimation of plasma glucose. What I mean by plasma glucose here simply means that we estimate and measure the amount of sugar you have inside your blood. That is plasma glucose. The second thing we do is we estimate the amount of glucose you have inside your urine. These are the two main tests we can carry out when we want to tell whether you have diabetes or you don't have diabetes. Okay, but now how do we carry out this particular urine glucose test? We use a reagent called the Benedict's reagent. Okay, this is one method we can use to detect glucose inside a patient's urine. We use a reagent called Benedict's reagent. And what we do is that we are going to take 5 mL of this particular reagent, then we let the patient bring his or her urine, then we take, or we aspirate. When we say aspirate, you are going to draw some of that particular urine with a pipette, an equipment called pipette, then we add it into the reagent, like 8 drops. 1, 2, 3, 4, 5, 6, 7, 8. When we put it inside the reagent, if there is sugar or there is glucose inside the patient's urine, that sugar is going to react with the Benedict reagent and it will lead to a color development. So it will change into a different color. Now the type of color that is being developed will give us a fair idea as to whether the patient has glucose in her urine or the patient has no sugar in his or her urine. So it might be green color, which will give us a fair idea that, he has maybe less than 0.5% of this in his or her urine. Maybe a green yellow color, maybe a red color. I hope you get the whole idea. So yes, we can measure your glucose in the urine by using what we refer to as the Benedict's reagent. Okay. Now, another way we can measure the glucose in urine is using what we call the glucose oxidase method. Now, with the glucose oxidase method, what we do is that we have a paper, okay, a filter paper or a paper strip. We take this paper strip, then we dip it into an enzyme, which is referred to as the the glucose oxidase enzyme and also a peroxidase enzyme. So after dipping the paper in those enzymes, okay, it should now become wet. Then we dip it inside your urine and wait for 1 minute and see whether the paper will change in color or not. Depending on the type of color, we can also tell that you have sugar inside your urine. Okay, now you might be asking, why is it even necessary to, detect sugar in urine? The reason being that under normal circumstances, normal individuals do not have sugar inside their urine. There is no way you should find sugar in a normal patient's urine. Even if you find, it should be very, very minute. Okay, so for people that are diabetic in nature and they have too much sugar inside their blood, there's something we call the renal threshold. What do we mean by the renal threshold? Now, every substance in our blood has its own concentration, it has its own range. Now, when it gets to a peak where it is over its normal concentration, the body cannot tolerate it anymore, so it wants to filter it through your kidney so that you can urinate it out. Now, when it gets to the kidney will also try itself to be able to reabsorb the substances. But the thing here is that for glucose or for sugar in particular, the threshold for it to get into the kidneys is like 180 milligrams per deciliter. So if you have any sugar levels inside your blood that is more than this particular amount, it simply means that you are not lucky, because it's going to get filtered through your kidneys, and then we'll see it inside the urine. And this will give us a fair idea that this particular patient is suffering from diabetes. But this particular type of test, as in determining glucose in the urine, is not really diagnostic, because other different things can cause a patient to have glucose in his or her urine other than just diabetes. This is very key. So if you go to the hospital and they're only giving you a urine test, they're not really doing the right thing, which I know probably most hospitals wouldn't do that. Of course, they can't just measure your urine and not measure your plasma concentration. Let me give you the reason why. There's a type of disease we refer to as renal glucosuria. I'll get to it in a moment, but let me just give you a brief explanation of what it is. So renal glucosuria is a type of genetic condition where this type of patient tend to have a renal threshold lower than the normal people. The renal threshold for everybody is like 180 milligrams per deciliter. People with renal glucosuria have a renal threshold slightly lower than that. As a result of that, any slight increase in their sugar, getting close to that particular number, that is 180, will lead to what? To glucose inside their urine. It doesn't mean they are suffering from diabetes. No, it is just because of their genetic condition. That is why you have glucose inside the urine. And that is why I'm telling you that the measurement of sugar in the urine alone cannot give a definite diagnosis of a patient as to whether he or she is suffering from diabetes or not. So yes, this thing or this method is not a golden standard method. Okay, so yes, let's move on to the next one. So like I said, estimation of plasma glucose. Now this plasma glucose can be estimated by looking at a range of different things. We have the RBG, which is referred to as the random blood glucose. We have the fasting blood glucose, which is the FBG. The third thing here is the oral GTT, oral glucose tolerance test. And then the fourth thing here is the 2 hours post-prandial blood glucose test. Let me explain each and every one for you here. The first, as you see in here, is the what? Is the random blood glucose. What do we mean by the random blood glucose? Now, when we say random blood glucose, let's say a patient comes to the hospital. And when the patient gets to the hospital, we don't care what the patient has eaten, whether the patient has done this. We just take the patient sample. So we refer to that as a random sample. So we can take the patient sample, blood, and we take the patient's urine in order to estimate it for the presence of sugar. All right. Now look in here. You can see the random blood glucose here is usually, the normal range is between 110 to 180 milligrams per deciliter. So when we just take your sample randomly, without actually knowing whether you've eaten, you've not eaten, you've done this, like maybe through a screening process or something. You've not had any specific medical advice. You just came to the hospital and we took your sample. That is why we refer to it as a random sample. Usually we expect that your random sample when we are checking for glucose or sugar in it, it should be between this range, 110 to 180 milligram per deciliter. However, when you have it more than 180 gram per deciliter, in that it is almost up to 200 milligram per deciliter. This gives us a fair idea that this patient might be suffering from diabetes. Take note, it is not diagnostic of the disease, not really diagnostic, but it will give you a fair idea that this patient might be suffering from what? From diabetes. Likewise, when you measure the patient's random blood glucose, okay, you just take the patient sample from the hospital and then you measure it inside the what? The lab. And then the result comes out to be normal. It doesn't also mean the patient doesn't have diabetes. The patient might still be suffering from diabetes. In other words, I'm trying to tell you that the random blood glucose that is usually measured in the hospital is usually an inconclusive way of diagnosing diabetes. I hope you get that. So yes, because it is inconclusive, it is not definite, it cannot tell us specifically whether the patient has diabetes or not. It cannot really be diagnostic in one way or the other. It just gives us an idea of what is happening. Either ways, we'll have to move on to the next one, which is referred to as the FBG, the fasting blood glucose, as you can see in here. What do we understand by the term fasting blood glucose? So, before you get to the hospital, maybe in the morning, the night before you get there, at least, I'm shooting this video, it's very, very late now. Let's say I'm going to sleep now. If I sleep now, till the next morning, you can see that I've not eaten for the whole of that night, midnight, dawn, till the next morning. This is a fasting period for me as I was sleeping. So you have to stay in that state of the fasting. So you get to the hospital early morning, then the doctor can take your blood sample and also take your urine sample in order to measure the amount of sugar or glucose inside your sample. And that is why we refer to it as the fasting blood glucose. In other words, we took your sample when you were in the state of what? Of fasting. So fasting blood glucose. Usually when we measure a patient fasting blood glucose, it should give us a range of like 70 to 110 milligram per deciliter. That is the range you should have. This is the normal range. Okay. Now for patients that are exceeding 110 and getting to somewhere around 125 milligram per deciliter, they are not diabetic. They are said to be pre-diabetic. In other words, they are at the risk of getting diabetes. They can be diabetic any moment from that time. I hope you get that. However, when they hit on the 126 mark, which is 126 milligram per deciliter, it means it becomes diagnostic. However, here is the twist again. There are some diabetic patients, even if you measure their fasting blood glucose, it will still give you a normal amount, in which case you can misdiagnose the patient and think that no, the patient is not suffering from diabetes. However, the patient is still showing signs and symptoms of diabetes. So you can see the fasting blood glucose also has a drawback and it's not really conclusive. Another problem, right? Exactly. So now we move on to the next step, which we refer to as the oral GTT. It is called oral glucose tolerance test. Now this is very important. So open your ears, because this is where you have to prepare yourself before you even go to the hospital. Listen here. So the oral glucose tolerance test is a test that we carry out when the random blood glucose and the fasting blood glucose are inconclusive. We are not really getting a fair idea of the patient's condition. Then we move on to the oral glucose tolerance test. That is why we carry it out, in order for us to be able to get a definite diagnosis of the diabetic condition. I hope you understand what I'm saying. Very good. But the question here is, you as a patient, how do you prepare yourself before coming to the hospital in order to undergo an oral glucose tolerance test? The first thing you have to do is that 3 days to the test, you'd have to eat certain amount of carbohydrate, food that contains carbohydrate. At least more than 150 grams of carbohydrate should be consumed 3 days to the test. Let's say you are doing the test today. So 3 days from behind, you'll be eating carbohydrate, a lot of it. The second day, the third day, before the day of the test. So 3 days to eat about 150 grams of carbohydrate. Do not take alcohol. You don't need to take caffeine. You don't need to smoke. There are certain drugs you don't even need to take. Okay, like drugs like oral contraceptives, and this actually goes to the women. You don't need to take oral contraceptives when you want to go for an oral glucose tolerance test. Otherwise, it will affect the results. You don't need to take all those things. You don't need to move your body too much. And what I mean by that is you don't need to do some strenuous type of exercises. And this is the way you prepare yourself in the house. 3 days to the test before you even go to the hospital. All right? Now, when you get to the hospital, the doctor is going to give you a seat to have your seat, and they are going to give you a glucose dose. I mean, I told you carbohydrates cannot be absorbed directly like that, isn't it? What can be absorbed directly is the glucose, isn't it? So, the day you are going for the test, don't forget you've already slept overnight, almost like 10 to 12 hours in that particular night before the next morning, right? So, immediately you get to the hospital, they give you a seat, we take your sample, and that sample is going to be referred to as your fasting sample. Don't forget, fasting because you fasted midnight before coming to the hospital, and that is after you've done all the things I've told you. You are not eating this, you are not smoking, you are not drinking, you are not all those things, okay? So first you come to the hospital, you don't take your fasting sample. After taking your fasting sample, we give you a gap of 1 hour, okay? We take fasting sample, your blood, and then your urine. Then within a gap of 1 hour, okay, we give you a glucose dose. Now this is directly glucose, so nothing like a digestion has to take place. We just take it in, it gets absorbed, and it gets into the blood. Okay, so we give you that particular glucose after 1 hour. Then we take your urine sample again. After 2 hours, then we take only your urine sample again, and also your blood sample, but without actually giving you a glucose dose. So the glucose dose is given once. Let me repeat the whole idea again. We take your fasting sample when you come in the morning. After that, we give you a glucose dose. That is after 1 hour. Then we take your sample, which is your blood sample and then your urine sample. Then afterwards again, we don't give any glucose. We just take your what? Your urine sample and then your blood sample again. Now this particular procedure all entails what you refer to as the oral glucose tolerance test. Now you can observe the timing here is 0, 1, 2 hours. This is a modified test. In the olden times, we used to make it 0 minutes, 30 minutes, 60 minutes, 90 minutes, 120 minutes, in that order. But we realize that the results that is generated from all these minutes is the same thing that we get when we conduct 0 hours, 1 hour, and 2 hours. And that is where the name 2 hours postprandial blood glucose comes from. In other words, it is a modified version of the oral glucose tolerance test. Because with the oral glucose tolerance test, it used to be what? 0 minutes, which is your fasting time, 30 minutes, 60 minutes, 90 minutes, 120. But this one is just 0, 1 hour, 2 hours. So I hope you guys are getting the concept here. These are the series of steps we use to check your blood sugar levels. Now let's understand what is happening after 1 hour, after 2 hours, after this. I mean, this brings us to what you refer to as the diabetic curves. Diabetic curves. Let's look at the first type of curve in here. You see in here we have a normal curve. Now don't forget, we actually are able to understand these particular types of interpretation based on this particular normal ranges. And mind you, these ranges might differ from hospital to hospital depending on the type of equipment and the type of test kit they are using. So this is a general form of the ranges people tend to use, but it might differ from hospital to hospital. So don't worry when you come in a case where you have your random blood glucose around 109, 111 or something. Don't worry about that, okay? It is still normal because it differs from one place to the other. Alright, so this brings us down to the types of curves. Now, in reference to this, you can see that with this particular type of curve, now this one here is representing the concentrations of the sugar we have inside our blood. So here, let's say we have 50 milligram per deciliter, we have 100, we have 150, we have 200, we have 250. The normal range, this 0 here means a fasting sample. The normal range for a fasting sample is 70 to 110 milligram per deciliter. So when we measure your blood, okay, for sugar, and then we get someone, this is 50, so we can say 60, 70, 80, 90, I mean somewhere around 90, right? 90, as you can see, is within the normal range, 70 to 110. This 90 falls within that particular range. So yes, this one here, we are getting something normal here, that's very good. After 1 hour, we give the patient a glucose dose, like I said earlier on. So when we give the patient a glucose dose to take, what we are expecting is that this glucose should be directly absorbed by the intestines and get into the blood. So logically, we are expecting that the sugar of the fasting blood glucose should be lower than that of the 1 hour. Because when we give it to you, they are expecting that there should be an increase in the amount of sugar in your blood now. So that is why you see a sharp increase in this particular curve in here. Now, when you look at the sharp increase, it is somewhere around 150 or something, right? Somewhere around 150, okay? Which actually makes sense, because when you usually have somewhere between 130 and 150 after you've taken in food, it makes sense that your sugar is actually up. But don't forget, it shouldn't exceed the renal threshold. This is the renal threshold, and I've explained what the renal threshold is. I mean, it is the threshold at which sugar will be filtered inside your urine. So yes, of course, the sugar has increased, but it has not gotten to that particular threshold, isn't it? Now, after 2 hours, we are expecting that this sugar that is inside your blood now will be made use by the cells. I mean, to be put into good use. In other words, your cells will begin to use them. So we can also use this particular part between the 1 hour and 2 hours to estimate your insulin function, to see whether your insulin is working well or not. If your insulin is actually working well, then the insulin should be able to help bring the glucose from the blood and send it into what? Into your cells to make good use of it. In other words, when they are bringing it from the blood, then the amount of glucose in the blood should begin to what? To decrease. And that is why you see a dip in this particular curve here. That is after the what? The 2 hours. I hope I'm making sense in here. So this 0 to 1 hour can help us estimate the absorption of glucose. From 1 hour to 2 hours can help us estimate as to whether your insulin is functioning well or your insulin is not functioning well. However, when it is coming down, we expect that it should be coming somewhere around the fasting blood glucose, or maybe slightly below the fasting blood glucose. And when this curve can be gotten from your results, they will be saying you are a normal patient. You have nothing. You are suffering from nothing. So as you can see from below, usually when the fasting blood glucose is between 70 to 110, after 1 hour it is somewhere around 130 to 150, and after 2 hours it falls to the fasting levels. After 2 hours, it has fallen back to the what? To the fasting levels, or maybe slightly below it. There is no problem with that. We say this patient is actually normal and the patient is not diabetic in any form. I hope this diagram is understood. Now let's move on to the next curve. Now with the next curve, now in reference to this again, 0 here means your fasting sample. We've taken your blood and we've taken your urine, and we know what a fasting sample means. The normal range usually should be 70 to 110 milligrams per deciliter. The thing here is that diabetic patients, their fasting sample might either be normal or they might be abnormally increased. Two things might happen. Okay, but here I've just represented it as something that has already increased. As a result of that, I have somewhere around 150, which is actually more than 110 milligrams per deciliter. I have represented it here on the diagram as something that has increased. But don't forget, in the hospital, that is not what happens. I'm just using this as a hypothetical example. However, it might either be increased abnormally or it might be in the normal range, but still the patient is diabetic. So what do we do now? After the fasting sample, we are going to give the patient a dose of glucose. When we give you a dose of glucose, the same concept, you expect that the glucose will be absorbed from your intestines and deposited into your bloodstream. So in other words, you expect that you have an increase in glucose. However, that increase in glucose doesn't mean that it should be increased to the extent that it is going to hit the renal threshold and get filtered in your urine. We don't want that to happen, please. We don't want it to happen, okay? However, for patients with diabetes, whatever you do, in most of the cases, their sugar level after 1 hour, that is after we give them the glucose dose, it increases to the extent that it exceeds their renal threshold, which is the 180 milligram per deciliter mark. It is going to exceed the renal threshold, and you begin to see the glucose inside their urine. So let's observe this graph. The fasting blood glucose, as in the 0 minute or 0 hours, was 150. And after we gave them a dose of glucose, it increased dramatically. Look at it, just increased like that to somewhere around 250. Bro, 250, that is a lot. The renal threshold is what? It's 180 milligram per deciliter, and it has over exceeded the renal threshold. In other words, we are going to find glucose in the patient's urine after we take the 1 hour sample. Because each and every sample, we take a fasting, that is a blood sample, together with the urine. Okay? So after 1 hour, we are going to get what? Sugar inside the patient sample. So in the urine, it's going to be what? Positive for sugar, which is a very good indication of diabetes. Now, after 2 hours, what is going to happen? We are expecting that the amount of sugar you have inside your blood should at least decrease. However, in this particular diabetic patient, although it will decrease, but it is still not decreasing below the renal threshold. As you can see, it has increased dramatically, but the dip here is not still below the renal threshold. Bro, this even makes it more diagnostic of a diabetic patient. Okay? So yes, this curve you are seeing in here is referred to as a diabetic curve, because after 1 hour, the glucose level actually exceeded the renal threshold, and after 2 hours, the glucose cannot even fall below 140 milligram per deciliter. I mean, 140 somewhere even just below the renal threshold. This glucose wouldn't even fall below that. It is still above that. All right. Even if it falls below that, and there's no significant fall in it, maybe 10 milligram per deciliter below the 180, it is still diagnostic of diabetes. All right. So you can see a trend in here. Diabetic patients have so much sugar in their blood that it gets filtered by the kidneys, and you can subsequently find it inside the urine. Now let's move on to the third type of curve we have in here. I'm almost tired. Let me pause the video and come back again. So yes, the third thing we have here is the lagging curve. What can we say about the lagging curve? Now, during the fasting sample or the fasting period, where we take your blood sample, we also take a urine sample, you find out that the fasting sample tend to be normal. The amount of sugar we have inside your blood is normal, because when you compare it to the normal range, the fasting blood glucose, you have 70 to 110 milligram per deciliter. Now when you look on the graph here, we have 50, 60, 70, 80, somewhere around 90, as you can see, just below the 100 mark, meaning that we have a normal amount of fasting blood glucose. That is a very good sign, isn't it? But you can see, after we gave the patient a glucose dose, which is after 1 hour, what happened was that there was an increase in the amount of glucose in the patient blood sample, which is very, very good. It makes sense because we need to absorb this particular glucose. But the thing here is, we don't want that particular glucose to exceed the renal threshold. If not, it is going to appear in the urine, and we don't want that to happen. When it appears in the urine, it gives us a little bit of some diabetic type of signs. So we don't want that to happen. But just look at this curve. What is happening in here? It has exceeded the renal threshold. As you can see, it has exceeded the renal threshold. However, after 2 hours, what happened here is that the sugar actually began to decrease. It began to decrease and decrease and decrease. And if you look at the type of the decrease we have here, there is a sharp decrease in that it is almost getting closer to the 0 mark. Okay? Now, this type of curve you are seeing in here is referred to as a lagging curve. And this usually occurs in patients that have undergone partial gastrectomy. When we talk about partial gastrectomy, the name itself, gas has to do with something that is concerning the stomach, okay? Stomach, intestine, that can something of that sort. So gastrectomy may be a certain part of your intestines, large intestine has been cut short due to a special type of operation or procedure you went through, and this is what is causing your sugar levels to give us this type of curve, okay? So yes, this is referred to as a what? As a lagging curve, and it's usually found in patients with partial gastrectomy. Now, this is the fourth curve we're going to talk about. The fourth curve, as you can see from the name, is referred to as a flat curve. Why do we call it a flat curve? We'll get to see it in a moment. Now, 0 mark, fasting blood sample, and then the fasting one, the urine sample we get from them. Now, if you look at the fasting sample in here, you can see it's on the 50 mark. The 50 mark, why is it on the 50 mark? Let's compare it to the fasting blood glucose, 72 to 110 milligram per deciliter. Look at 50. 50 is below that. So in other words, even during the fasting period, this man's sugar is still around the 50 mark. After 1 hour, after we gave the patient a glucose dose and monitored the patient after just a period of 1 hour, the glucose, of course, if you give you a glucose dose, you expect that there will be absorption, and then, of course, there will be an increase in the amount of glucose inside your bloodstream. However, if you look at this patient, the amount of glucose has increased, but there's no significant increase in it, in that it has not really even gotten to the normal level of the glucose concentrations in the blood. Although there's an increase, but the increase is very light. There's nothing much. And after 2 hours, there is a decrease also, almost around the same mark. So you can see it was very, very low with the fasting sample. It's increased, but nothing much, and it's also decreased, and it's almost on the same mark. We refer to that as the what? As the flat scale. And this usually occurs in patients that have a problem with their endocrine system. It is hypofunctioning. So conditions like hypopituitarism, hypothyroidism, all the hypo endocrine related stuffs can lead a patient to have this type of curve, which is the flat curve. Now this brings us to the fifth step again, which is renal glucosuria. I explained this earlier on in my video, but I'm still going to re-explain it again in order to solidify the concept for you guys. Now, in the case of renal glucosuria, what is happening in here? Now, this is a 0 mark. The patient has actually come to the hospital. We've taken the fasting sample. We now know what the fasting sample is. We've taken the blood sample. We've taken the urine sample. Now, we measure the amount of glucose inside that patient, and we realize the amount of glucose is like 75 milligram per deciliter. Let's come back to the normal range. 70 to 110. So 75 is within that particular 70 to 110 milligram per deciliter mark. In other words, we have a normal fasting blood glucose. Fasting one, plasma glucose sample. That is very good. So this is a 75 mark, okay? Now, after a period of time, we gave the patient a glucose dose, then monitored the patient for a period of 1 hour. Now, after the 1 hour mark, what is happening here is that there has been an increase in the amount of the patient glucose. There is an increase in the amount of glucose inside the patient blood, which makes sense because after we give you the glucose, we expect absorption to take place, and then we expect that the amount of sugar you have in your blood should also increase. But look at the twist in here. The sugar has increased. It has not exceeded the renal threshold. However, we can see that I've written positive here, which is an indication that there is still glucose in the patient's urine after 1 hour, although the glucose has not exceeded the renal threshold. And the reason being that this type of patient usually tend to suffer from a genetic type of condition, like I said earlier on, which makes their renal threshold lower than the normal. So if it's even getting a little closer to the 180, you see that the glucose will appear inside the urine. We call that type of condition renal glucosuria. Let's let it make sense. Glucose, from the word glucose, urea meaning in the urine. So glucose inside the urine as a result of what? Because you are having a type of genetic condition affecting your renal system, in which case it is reducing the renal threshold. I hope I'm making sense here. That is what we refer to as what renal glucosuria. So you can see that even after 2 hours, it now comes back to almost to normal again. So it actually looks like a what? A normal curve. This curve here looks like the renal glucosuria curve. The only difference here is that in the case of renal glucosuria, you find glucose inside the urine. Not because you exceeded the renal threshold, but because the patient is suffering from a genetic condition. And in here, everything is normal because the patient is normal. The patient is not suffering from anything. So these are some of the curves we can come across inside the laboratory. Okay, these are some of the things they have to do in order to see whether, oh, what is this guy suffering from? What is happening to this? What is doing this? What is doing all those things you see, the magic happening. It is all the magic I've given to you here for free. Okay, so it's just up to you to understand the concept and see how to interpret your laboratory results. Now, the video is almost done because I'm very, very tired. I would have loved to talk about, the management of diabetes. How are we supposed to take care of our diabetic patient? What are some of the drugs we can give to this diabetic patient? What are some of the advice I have for this diabetic patient? I would have loved to complete this video, but I'm tired, so I'll leave it for part 2. And please don't forget to subscribe to my channel. If it's on Facebook, don't forget to follow the page. Don't forget to like. Leave all your questions in the comment section. I'm going to try my possible best to answer each and every question that will be left in the comment section. Okay, but before we close up everything, I want to show you something here. Now, you see all these things, the estimation of the plasma glucose. How do we detect the glucose inside the blood? I'm giving you a detailed explanation of how we detect the glucose inside the urine using Benedict reagent and then glucose oxidase strips. I've given you that explanation already. Now I want to tell you how we exactly know that this is the amount of glucose we have inside your blood. How do we do that? The method is the same for all these things. 1, 2, 3, 4. It is the same. How do we do that? So what we do is that we are going to take the patient's blood. Okay, when we take the patient's blood, look at what we are going to do. We are going to centrifuge the patient's blood. Now when we get the blood, we're going to put it into a test tube. These are small tubes. In fact, let me take my marker to make this thing make more sense here. Okay, so this is a test tube inside the lab. We'll put the patient blood in here, then we put this particular tube in a certain machine called the centrifuge. Then we on it, then later on the blood or the red blood cells are going to settle at the bottom of the tube. So you see that they are going to be packed here. Then there will be a certain type of liquid on top. Then we refer to that liquid as what? As plasma. Okay, now it is this plasma that we tend to measure the glucose in. So we are going to use our pipette to take a volume of this particular plasma, which is 10 microliters of that, from the patient what? Sample. Okay, so hold this in what? In mind. So let me show you something. This is my view, this is my tube, this is another tube. So we are going to take 10 microliters of this and put it into this. This is the what? The patient sample. Okay, this is the patient sample. Now this is a standard. This is something that we already know its concentration. For the standard, we produce it in the lab. Sometimes we can even buy it from other companies that are producing it. Okay, so when they bring in the standard, we'll take 10 microliters. 10 microliters is very, very small. So we use a particular type of equipment called a micropipette. It is something that we press in, and we can press and can leave it to come out again. So we use that to take that measurement, both for the plasma sample and also the standard that we prepare. Then we put 10 microliters of that particular standard. Then later on, we have a reagent called the glucose reagent. We are going to take 1 ml of the glucose reagent, 1 ml of the glucose reagent. We put it in this, and we put that same 1 ml also in this one. So at the end of the day, you can see we have 1 ml of glucose reagent. We have 10 microliters from the patient sample into our sample container, and then from the standard that we prepared into our standard 10 microliters. You understand that? Then we are going to measure these two things using a tool called the calorimeter. You can use a spectrophotometer depending on what type of equipment you want to use to analyze that particular patient sample. Now, in most of the cases now, we don't even do the things manually, but the machines are going to do it. But this is the concept behind it. And this is how we manually do it when we go to places that are like villages. You go to places where there are no equipment and stuff. This is how you manually do it, okay? So that is exactly how they are going to use to estimate your plasma glucose. But the thing is, what are the chemical reactions occurring in it? What the concept behind here is, inside the patient sample there is glucose, right? And the reagent also consists of a number of things. They have glucose oxidase, they have peroxidase, they have 4-amino antipyrine, they have this, they have that, a whole lot of things. So the whole idea here is that the glucose that is found in the patient sample is going to get oxidized by an enzyme called glucose oxidase enzyme, which will lead it to convert into a glucuronic acid or glucuronate and hydrogen peroxide. That is the end product. Now this hydrogen peroxide is going to react with 4-amino antipyrine within that particular sample in the presence of a molecule called phenol, okay, in the presence of a substance called phenol, then an enzyme called peroxidase, and then later on we are going to get a substance called quinonamine. Now this quinonamine is like a dye. It is a color that is going to develop after all this reaction has taken place. So you see that there will be a change in color in both samples, and that change in color is what we measure. Now the answer or the results you get from that color is directly proportional to the concentration of glucose that is found inside the patient sample. So we put that into a formula. This is how the formula goes. So we put it in the machine. We are going to get an optical density. The reading you see from the machine is called an optical density. So if it is that of the sample, you write the optical density of the what? Of the patient sample over the optical density of the standard, the one you prepared from the lab, times, since you prepared it, so you know the concentration, so times the concentration of the what? Of the standard. This one has to be measured, this has to be measured. How do we measure? We put both things into the what? The machine. The machine will tell us a specific reading, then we put it there. This also, then we put it here, but this one we already know it. Now when you make this calculation, this should give you the specific or the more accurate concentration of glucose you have inside the patient's plasma. In other words, the patient's blood. What is the amount of glucose you have in there? And that is where we get all these answers from, whether it's 500 milligram per deciliter, 200 milligram per deciliter, 20 milligram, whatever milligram per deciliter it might be. However, there are certain lab results that when it comes, they don't write it in milligram per deciliter. You see it in millimole per liter. The thing here is that we run a conversion. Okay, how do we do this conversion? Let's say, for example, the board is messed up. Let me clean some parts and see what we can do here. Please let me just clean this part. I hope the concepts are becoming clearer. Let me just clean this part and let's see what we can do here. So let's say you've gotten a lab results of like, let's say 80 milligram per deciliter. Okay, this thing can be converted into millimole per liter, which is a different unit. And how we do that is that we calculate it as milligram per deciliter times 10 all over the molecular weight of that particular substance you are measuring. So we are putting this number we've gotten into this, we multiply by 10, then over the molecular weight of the substance. So if you are measuring for glucose, you have to look for the molecular weight of glucose. Go to Google, all the molecular weights are there. If it is urea you are measuring, you put the molecular weight of urea down there. If it is uric acid, if it is creatinine, whatever thing you might be measuring, put it in there, and then it will give you the answer in a unit. So we have answer, and then the unit is going to be millimole per liter. Alright, so I think this should bring us to the end of our video. So as you can see here, I've explained to you what diabetes is. We've explained the investigation of diabetes, how to estimate the diabetes in the lab, some of the things to expect, some of the things to even do before you get into the lab, and then I've chipped in a lot of different things alongside the way. The last thing is to talk about the management of diabetes and then the cure. Sorry, we don't really have a cure for diabetes. Yes, people might claim they have a cure from a herbal, point of view and other different things, but what I personally know is that we don't really have a cure, but we can manage the diabetes and we can give some drugs to help with the situation. Okay, so I'll try as much as possible to create a separate video on that, because this video is so long. So if you like this video, please follow my page. I really want to grow this page so that at least we can be sharing a lot of things on that particular page. Thank you very much for being with me, and I hope to meet you in my next video. This is Rick One, Salifo.